Welcome to this session. I'm Sandra Ogunremi. I oversee diversity, equity, inclusion, and spiritual care services for Monument Health. Our session is Adjust Your Lens. It is never too late to refocus. Our course objective. At the end of this course, you'll be able to understand, identify, and mitigate unconscious bias and the impact it has on perspective taking and decision making. We want to go over personal commitments. We want this to be your personal commitment, my personal commitment, our personal commitment. I will commit to opening my mind to learning a new way of looking at things. I will commit to suspending the internal dialogue and debate that occurs when information is being presented. I will commit to leaving this presentation with information and techniques that I can apply. I will commit to using the acronym THINK before I speak. Is it true? Is it helpful? Is it inspiring? Is it necessary? Is it kind? We want to ensure that we think before we speak. What do patients see when they see you? Your appearance, your race, your language, your accent, your introduction, your qualifications. You have great influence on what people think of you in the first 5 seconds. The book Blink talks about the power of thinking without thinking. Within the first 5 seconds, most people have thoughts and have reached some conclusions based on them thinking and based on them being in fast thinking mode. So what do patients see when they see you? When you stand in front of the mirror, what do you see? If you were a patient, what would you think about yourself? If you look in the mirror before you leave the house, what do you think that patients will see when they see you? And that should impact your presentation to patients. What do you see when you see a patient? Again, appearance, race, language, accent, introductions, qualifications. We can go on and expand it more. Uh, the way they are dressed, appearance, right? Socioeconomic status. Are they dressed nicely? Are they not dressed nicely? Are they clean? Are they not clean? What conclusions do we reach when we see our patients? Are we empathetic? Are we compassionate? Or are we judgmental? What goes through our minds when we see our patients? It is so important that we understand how we think because that affects our perspectives of the patients we're taking care of and the decisions that we might potentially make. What causes us to spend more time with patients? Is it because of the patient's health condition, or is it because they're very pleasant and easy to talk to? What causes us to smile at patients? What causes us to be reserved? What are all the things that impacts negatively our perspective of our patients? What causes us to slow down, to relax, and what stresses us out and makes us uncomfortable? These are questions that only you can answer. But we'll give you tools and thoughts that you can, things that you can think about that will help you in deciding how best to take care of patients by limiting and reducing unconscious bias and some of the biases that we have, cognitive biases that we have. So you think about cognitive, it's really, it's your thinking, it's relating to or involving conscious intellectual activity, such as thinking, reasoning, or remembering. You think about reasoning, mental thinking. You might say, let's have a meeting to discuss this situation. So it's cognitive, intellectual. Let's put our minds together and see what great results we can have. Perspective taking and the way that we see things, our perceptions, rational. Let's put our minds together and come up with some rational decisions. It's going to be rational. It's not going to be emotional. So cognitive really involves thinking. And then we think about the word bias, and it's a tendency, inclination, or prejudice towards or against one thing, person, or group compared with another. So it could be to prejudge, prejudice, unfairness, favoritism, preferences, preconceptions, influences, partiality. Most of us have that teacher that we kind of felt had a favorite student. So there was a bias towards a student. And maybe I've taught a class where the person says, well, I was the one that the teacher liked the most, and I later on didn't quite like it. We all have, those situations where we go, this person just is treated differently and better. Or you might be the one who is not treated so nicely, or you might be the one that's treated nicely. But we tend to see that maybe this isn't fair. Siblings in particular will tell stories of, the firstborn had to be responsible. The baby was still a baby at age 80, you know, and the middle child is maybe forgotten. It's not intentional. Parents are thinking, It's not intentional. Parents are actually really thinking, but unfortunately, cognitive biases occur. Tendencies towards one, tendencies against the other without thinking about it. So a cognitive bias, a systematic error in thinking that occurs when people are processing and interpreting information in the world around them, and it affects the decisions and judgments that we make. There are at least 150 identified cognitive biases. Researchers at the Neuroscience Leadership Institute have grouped these common biases into 5 categories. You think about similarity. We prefer what is like us over what is different, and we'll be expanding on that. Expedience, we prefer to act quickly rather than to take our time. Experience, we take our perception to be the truth. Preference, distance rather, we prefer what's closer over what's further away. Safety, we protect against loss more than we seek out gain. If you can't explain it simply, you don't understand it enough. And that's so when I teach, my goal is that everything that I say is easy to understand, can be easily applied. We can pivot, change, grow, develop, be better versions of ourselves, and make a positive difference. So you think about biases again. 11 million pieces of information per second is what the unconscious mind is able to process. 11 million pieces of information per second. Compare that to the estimate for conscious processing, about 40 pieces per second. So our brain takes cognitive shortcuts that can lead to unconscious bias. Our brain wants to stay safe. Our brain wants to feel comfortable. Our brain wants to know, is this a flight or fight response that should occur? Am I safe? Am I not safe? Do I need to be guarded? Do I not need to be guarded? Am I able to take care of this patient? Am I not able to take care of this patient? Is this person, am I comfortable in the presence of this person? Can I let my guards down? One of the duties of our mind is to protect us. So many bits of information coming at us. We can't process it all. Our brain will take cognitive shortcuts. Cognitive. So we're thinking, but we're making systematic errors. Explicit bias, conscious bias. It's expressed directly. We are aware of this bias. It operates consciously. You might have someone say, I do not want any doctor to treat me except if they are tall, male, between the ages of 45 to 60, because they're going to be my surgeon and I want to make sure they're in tip-top shape. Well, that's been expressed directly. So ageism has come in, and sexism has also been mentioned, expressed directly. Or you might have a provider that says, I will never treat all these millennials running around. They tend to be rude. Or these Gen Zs that have entered the workplace. That is explicit bias. It's being expressed directly. You're aware that you're saying it. Or you might say, I don't want to work with anyone who's a redhead because I know they get very angry easily. They're fiery. That's expressed directly. It's explicit. We need to pay attention to what we say, because if we hear what we say and pay close attention, we'll be able to identify some of our biases. Implicit bias, it's unconscious. It's expressed indirectly. We're unaware of it and it operates subconsciously. We might feel uncomfortable. We may not know exactly why we're uncomfortable, but we might feel uncomfortable. We might not want to treat a certain type of patient based on race, based on religion, based on ethnic factors, based on weight. There's weight bias that people don't tend to talk about. We don't want to treat this patient who's 500 pounds. Is it because of the complications, or is it because, well, it's their fault? They should not have eaten so much so that they are now 500 pounds. What's going on through your mind? If it's implicit, if you're just feeling uncomfortable and you're not sure why, force it to the forefront, confront it and say, why don't I want to treat this patient? Why am I not feeling empathetic or compassionate towards this patient? Why do I feel like it's their fault? Could it be their fault? Could it not be their fault? Our place in healthcare is to take care of the patients with compassion, with empathy, without judgment. And so if you are uncomfortable taking care of someone, if you're uncomfortable spending time with someone, ask yourself why. Why am I uncomfortable? Why am I feeling the way that I'm feeling? Why am I thinking the way that I am thinking? Conscious bias, again, attitudes and beliefs we have about a person on a conscious level. Unconscious bias, a bias that we are unaware of and it happens outside of our control. 11 million pieces of information per second. A lot of it comes through our eye gates and our ear gates. We've got to be very careful what we pay attention to, what we see, what we hear, and how we process it, because we're going to be looking at some of these biases: anchor bias, affinity bias, confirmation bias, attractiveness bias, halo effect, Horn's effect, performance bias, um, and bias blind spot. I'm going to talk about them really quickly. Anchor bias, it's what anchors you. Think about an anchor of a ship. The ship can go in a circumference around it, but the ship can't really go too far away from it. Anchor bias, the information that we get that anchors us. Affinity bias, we tend to like what is like us, whether it's based on race, political view, religious views, community service, gender, age. We tend to prefer what is like us. So if I walked in a room and I suddenly said, hallelujah, some of you will suddenly like me, while some of you may not like me. Think about the fact that bias, for or against. Affinity bias is for, similarity. And so if I dress like you, act like you, believe what you believe, have similar values, volunteer where you volunteer, like the same football team, like the same, we just had the Super Bowl, we rooted for the same team, affinity kicks in, we might become very good friends, and all of a sudden there's a positive bias. So think about that. That happens with patient experience. The difference between a 7 minutes of time with a patient and 8 minutes or 9 or 10 minutes could simply be based on affinity bias. Confirmation bias, and we'll be talking about that a little bit later, a little bit more. We tend to seek out information that confirms what we believe. And so we've got to be very careful to ensure that we are seeking out information objectively. As you deal with patients, as you deal with situations, as you try to confirm, a diagnosis or something, take the time to make sure you're not just looking for what confirms what you already believe. Attractiveness bias. We are attracted to what is cute, what is attractive. We have a positive bias. We prefer, we have a tendency for something that is attractive, someone that is attractive. So you walk into a patient room, they're dressed very nicely, they're put together, they smell good, they look good, 11 million pieces of information per second, your eye gauge, your ear gauge, your nostrils, and they reach out and they touch you and they say they appreciate you. So you've engaged a lot of your senses in those few minutes, and attractiveness bias tends to cause us to interact with people a little bit longer. We smile at them, we empathize with them, we are compassionate towards them. Attractiveness bias is real. And so we've got to watch out for that. Why is it that we're able to spend more time with certain patients? Not because of the health condition always, but sometimes it's because we feel a kindred spirit with them. We bond with them. They have good vibes. All of these themes are really subjective, and it's how we lean for or against. Halo effect, that first piece of information that we get, or the first interaction. Let's just say we have a good interaction with someone the first time we meet them. We suddenly deem them to be angels. Maybe they perform an exceptional surgery. They're new and they perform this exceptional surgery. Now they can live off of that reputation forever, that halo effect. And that is why in elementary school, middle school, high school, parents will tell the children, make a very good first impression. What they're saying is, let the halo effect kick in. Let the teacher see you as obedient, compliant, and all of that. And so patients who are able to understand this and they make a very good first impression might have a better long-term relationship with their provider. And providers who walk in and have that same halo effect on their patients, they end up scoring very high. You walk in and you go, oh, Mrs. Jones, I'm so happy to see you today. I'm glad we were able to squeeze you in. All of a sudden, good emotional intelligence, patient is feeling good. You're saying what you need to say. And that patient might leave and they might say, well, I hear he's not a very kind person. Patient has a different experience. Patient experience scores go up. Halo effect. And the next time when you don't have much time, you go, I'm so sorry that I'm running 15 minutes behind. Mrs. Jones, Mr. Jones might say, oh, don't worry about it. I was just reading a magazine. I was okay. Why? Halo effect. Horn's effect really is that theme. First impression, impression later on, that theme that causes you to not like a person continuously. So Horn's effect, like the devil's horn. They've done something and now they can't get out of it. Surgeon comes, probably makes a mistake, recovers from the mistake, patient goes on to live and thrive. 10 years later, everyone is still watching him because you never know. Don't take your eyes off of this doctor. Remember, there was a time. That's the Horn's effect. You can't dig yourself out of it. You can't live that down. People remember that. The same way as I said, people remember the rock star surgeon who saved a life, and he can live off of that reputation. Be very careful of the halo effect and the Horn's effect. Performance bias, bias blind spot, many different biases that occur. I'm going to talk about the bias blind spot really quickly, and that is don't be blind to your own blind spot. Don't have a bias towards your own blind spot. Be aware. Performance bias also is quite real. Sometimes we give people the benefit of the doubt of the performance that they can have versus somebody else. A female surgeon might be deemed to not be able to perform at the same level as a male surgeon. And so performance bias, we believe one person can perform better than another person. There's also the performance gender bias, which is what I've just described. Maybe someone who went to a certain university, you deem that they can perform better. So it's a bias about performance. And then somebody else, you think they can't perform as well. So one person has to spend their time proving themselves while another person gets a pass. Pay attention to some of those things so that we can avoid them. So we're going to do a quick question. People who tend to have higher levels of blind spot biases are less likely to accept advice from others, whether they are peers or experts, less likely to learn from training regarding reducing bias, quick to believe that they are less biased. What do you think the answer is? The answer is all of the above. The blind spot bias is similar in that it is something that affects the choices you make, even though you cannot see it. As you weigh a decision, many factors play a role in your thoughts. Yet it is often the factors we are unaware of that may impact these choices in ways we may not have considered. Bias is real. Blind spot bias can lead to faulty or distorted thinking, which can lead to poor decision making. Think about that. Confirmation bias, we've talked about that. The tendency of people to favor information that confirms their existing beliefs or hypotheses. We search for information, interpretation, memory that leads to us maintaining our bias. More weight to evidence that confirms our beliefs, undervalues evidence that could disprove it. So we lean towards what we believe. Confirmation bias consistently shapes the way we look for and interpret information that influences our decisions in this society. This bias prevents people from gathering information objectively. Be very careful of the confirmation bias. It is real. It impacts people every day, every hour, because we tend to lean towards what we think things might just be. Thinking Fast and Slow, groundbreaking research by Daniel Kahneman showed that our brain has two operating systems. System one is fast. The defining characteristics are conscious, automatic, effortless, without self-awareness or control. Its role is to assess the situation and deliver updates. Our mind is constantly updating us. Is there smoke? Do I smell smoke? Are there alarms going up? Am I safe in this space? In my office? Am I okay? It's giving updates. And as long as everything is okay, I'm going to be here. The first time I detect smoke, I'm out of here. What is it? Is it from the popcorn machine? Is it from the microwave? Is the building on fire? What are my escape routes? System one delivers updates. System two, some of the defining characteristics: it's deliberate and conscious, it's effortful, controlled mental process, rational thinking with self-awareness or control, logical and skeptical. The role seeks new or missing information as it makes decisions. It makes 2% of all our thinking. So we have to be able to slow down. We have to be able to slow down. We have to be able to say, am I missing something? Is this the same condition that I'm seeing, or is this different? How was the Omicron detected? This is different. What makes this different? How are all the variants of COVID-19? How are they being detected? Something is slightly different. System two kicks in, and it seeks new and missing information. And then tests begin to occur, and the results begin to tell us, okay, there's a new variant. Okay, this variant is going all over the world. Okay, this is what we're capturing. How do we test for it? If we stay in system one, we just think, is it the flu? Is it what variant, but system two forces us to pause and to think. Be very careful how you frame things. Thinking fast and slow, framing and choice. Your thinking and opinion can also change depending on how the information is presented. You're sitting in the doctor's office. The doctor looks at you and says you need major surgery. The doctor takes a deep breath and says, the chance of you dying within 1 month is 10%. Take a second to think about how you felt reading that sentence. Now imagine the doctor instead saying this: the odds of survival 1 month after surgery are 90%. How did you feel after reading that? It's exactly the same step but phrased differently. Most people feel that the second one is more reassuring despite being factually equivalent to the first. As providers, pause and say, how should I phrase this? How should I frame it? How should I say it? What are the words I should choose? Based on health literacy levels, if you hear the chance of you dying within 1 month, once you hear the word dying, you'll leave there saying, my doctor says I'm going to die. Why would I want that surgery? But if you say the odds of survival, then you can begin to explain more and you can begin to educate. But there are certain ways we say things that causes patients to be in the fast thinking mode, not to stay rather in the fast thinking mode, not slow down and process. So we want to make sure that we're able to help with the processing. The Dunning-Kruger Effect. The tendency for those unskilled or uninformed in a particular area to overestimate their knowledge or skills. Sometimes limited knowledge on a subject can lead people to mistakenly believe that they know all that there is to know. Experts will tend to underestimate their own knowledge. Think about that. We see that today. If you are on social media, people who have never taken a science class have become experts in COVID-19. Experts. While the true experts continue to underestimate their knowledge, continue to do the research, continue to try to figure out, is this what we should do? Is this what we should not do? Those who've never taken a science class are debating on, should we be vaccinated? Should we not be vaccinated? Should we wear masks? Should we not wear masks? Be very careful as you handle patients and people, because people who don't have as much knowledge are not aware of all the things that the people who do have the knowledge have to consider. They're not aware of all the variables. They're not aware of all the constraints. They're not aware of any of those things. And so the tendency for those who are unskilled or uninformed in a particular area to overestimate their knowledge or skills, quite real. And so be very mindful not to get frustrated and not to get into debates. The very knowledge and skills necessary to be good at a task are the exact same qualities that a person needs to recognize that they are not the best at that task. Hence why you think about the specialties that we have. We have so many different groups. You have rheumatologists and urologists and endocrinologists and nephrologists and cardiologists, and it goes on and on and on and on and on and on. Be more limited areas where you become an expert in, you have more knowledge about less, but a whole lot of knowledge about that aspect of the body. And so that is, the experts focus in on a smaller area and are knowledgeable, and those who are not experts feel like they can just diagnose without ever stepping foot in a classroom. Be very mindful and know how to handle it when your patients come after studying WebMD for 15 solid minutes. The Dunning-Kruger effect. The reality is that everyone is susceptible, and in fact, most of us probably experience it with surprising regularity. The key is not to correct for the effect by lowering our assessment of ourselves. Keep learning and practicing. Ask others how you're doing. Constructive criticism. Question what you know based on the area that you find yourself and the topics that you find yourself. So we're going to do a quick test your knowledge. The tendency for positive impression of a person in one area to positively influence one's opinion or feelings in other areas is known as the first impression error, halo effect, contrast effect, horn effect. Let's pause so that you can read that. And the answer is the halo effect. When forming a first impression, observing an initial attractive feature can make the person appealing, making it difficult to revise that impression based on new or opposing information. Be very mindful of the halo effect. Be mindful of the horns effect. The ostrich effect. It's a cognitive bias that causes people to avoid information that they perceive as potentially unpleasant. Common ways people avoid information: physical avoidance, inattention, biased interpretation of information, forgetting. Think about patients. Why is it that sometimes a patient doesn't come in until the pain or the swelling, the redness becomes unbearable? Why is it that they ignored it, didn't pay attention to it? Yes, there was fear, but sometimes it's easier to duck our heads in the sand. And so when you see that kind of a patient, uh, let the positive emotions kick in with empathy, with compassion. The ostrich effect is real. Why is it that people don't do their annual physical checkups? And why is it that people avoid certain specialties? Maybe they don't want to see the OBGYN every year. Maybe they don't want to do their annual mammogram. Maybe they don't want to do, and then when something goes wrong, why is it that the person still on the mammogram, why would a person wait when they felt a lump until it had tripled in size? Why would a person wait? It's because of the ostrich effect. We just try to not focus on it, hope it goes away, hope it resolves itself, hope it's nothing. And then when we realize it is something, is sometimes when people finally address it. Information avoidance can lead to detrimental outcomes in a variety of situations. Before making an important decision, or in general, you should ask yourself the following: is there additional information that I can obtain that will help me make a more informed decision? If so, am I pursuing this additional information, or am I avoiding it? If I am avoiding this information, why am I doing so? What do I stand to gain? What do I stand to lose? These are some of the conversations that you should have with your patients. What do you stand to lose if you do more tests? What do you stand to gain if we order more tests? Is there more information that we can get? Is there another specialist we need to get involved? We've lost some time. We want to try to gain back some of that time through expediting whatever it is, and we want to have the very best outcome. Find ways that you can use to talk to the patients to help them to not continue with the ostrich effect. So we're going to do a quick test your knowledge. What is the definition of confirmation bias? Being right but believing you are wrong. B, but people changing, altering facts to make an argument. C, the idea that people may pay more attention to information that agrees with their own beliefs. And D, deceiving others by confirming incorrect information. And the answer is C. Confirmation bias is the tendency of people to favor information that confirms their existing beliefs. The cultural iceberg, as we think about cognitive bias and trying to tie this together for decision making and perspective taking, the cultural icebergs, the patients you see, may not have the same cultural frame of reference as you. So much of the way we experience or express culture is through implicit concepts, attitudes, or approaches, ones that we might not even be conscious of. And culture is a way of life. It is not necessarily race-based or gender-based. It's a way of life. It's what we know, and you begin to think about some of the communication styles and rules, notions of courtesy and manners, concepts of fairness and justice, attitudes towards elders and children. It goes on and on. When I interact with someone who's typically from the South or have served in the military, I can tell real quickly because they say, yes, ma'am, yes, ma'am, yes, ma'am. They could be 15, it's yes, ma'am. They could be 50, it's yes, ma'am. They could be 20, it's yes, ma'am. And I can quickly tell because the notion of respect is to say yes, ma'am, and yes, sir. I can quickly tell when I interact with someone from the East Coast, maybe they speak a little bit faster. When I interact with people from the South, they speak a little bit slower. They tend to say sugar bun, honey, dear, the way they talk. When you think about different cultures and family and, you know, uh, who has authority, age. Some cultures say all your education doesn't matter as much as age. The wisest person in the room is the oldest person in the room because they have a wealth of knowledge based on experience. So this impacts how patients and caregivers and providers react and process things without people even being aware of it. The cultural iceberg, and 90% of who we are is within us. It's not the surface, it's not the blazer that I have on that determines who I am. The food, the dance, the games I like to play, the music I like to listen to. All those are cultural elements that people don't see 8 to 5, because when we come into certain settings, we tend to come in to perform certain duties in a certain manner. And so who we really are deep within us may not always surface right away. So according to the iceberg model, approximately what percentage of a culture is below the surface? Is it 10%, 25%, 50%, 90%? The answer is 90%. The iceberg model is a metaphor of an actual iceberg. We can only observe 10% of the actual iceberg, and the rest is hidden beneath the surface of the water. In the same way, when observing a culture, 90% of that culture is hidden from the casual observation, and we can only see the basic characteristics of the culture. So be mindful of that. Decision making, time spent with patients, treatment of patients, test orders. How do you ensure a level of consistency? How do you ensure you smile in similar ways to the patients, that you spend the same amount of time, and that you order tests? And it's not because one patient comes in and there's affinity bias and all of that, and when they cry, it tugs on you and you order more tests. Well, how do you ensure a level of consistency? We have to slow down and think carefully. Biases occur unconsciously, and awareness can make a difference. We sometimes treat the worried well, and we sometimes treat those who have conditions. Sometimes the worried well need reassurance, and sometimes the very sick need both reassurance and medical treatment. How do we determine? We've got to slow down, and let's not let our biases have us favor one group or one person over another. We want to treat people as best as we can consistently. Biases. Everyone has unconscious bias. Everyone does. I have them. I constantly work on them because I keep having information fed to me. 11 million pieces of information per second. Biases can be positive or negative. Biases may be for or against groups, things, people, or values. They support how we efficiently maneuver and manage in the world. They help us feel safe, confident, and valued. They are self-perpetuating. What are the biases we have of a person who's all tatted up and they have muscle sleeves on and they're big and they're buff and they have a long beard? Think about it. I just painted a picture. Would you want to be in the parking lot with them at 8 p.m. in the winter when it's really dark? We all have unconscious bias. And then we might learn later on that they are our surgeon. We might learn later on they are a pastor. We might learn later on they are an engineer. And all of a sudden, we will shift from being afraid to suddenly feeling safe. 98% of our thinking occurs in the fast thinking mode, system one, and it's trying to figure out safe, not safe. Should I be here? Should I not be here? And it's thinking, thinking, thinking. Unconscious bias tries to keep us safe. It's self-perpetuating based on the information we receive, on things we've watched. If you come from a culture where a tatted man with a muscle shirt, big muscles, long beard, if you come from a culture where that means nothing, you're not going to ever feel unsafe. But if you've watched enough movies where they have been stereotyped, then you tend to feel unsafe. So these are very real. How do we acquire them? Assumptions, judgments, our assumptions and judgments and beliefs and values and our sense of right and wrong, good and bad, through all the media that we see, through the different themes that we process, the media. Social media is huge now. We have got to overcome our biases by acknowledging and identifying that we have them. Learn about different types of biases. List ways that unconscious and hidden biases impact our behavior. Be very honest with yourself. Alter your patterns of thought. Learn to recognize and avoid generalization. Counter stereotypes with positive images. Expose yourself to things that make you feel uncomfortable. Put yourself in other people's shoes. Don't generalize. That's a cognitive shortcut. All male surgeons are this. All female surgeons are this. All female doctors are this. All male nurses are this. All blondes, all brunettes, all redheads, all black women, all black men, all people with foreign sounding names, all. We have got to avoid generalization. We have got to be able to treat people one on one. Individuation is so important. Treat people as individuals. and treat them and get to know who they are and interact with them based on who they are and not based on a stereotype. How do we overcome our biases? We make life changes. We increase opportunities for contact with a diverse range of people. It's a must. We must increase those opportunities. We must learn from people who are more tolerant than us, and we must surround ourselves with open-minded sources. We've got to adjust our lens. How am I seeing this? What's my frame of reference? Why am I thinking the way that I'm thinking? I've got to be courageous. I've got to be sincere and be genuine. And I've got to be a person who can really think correctly. I've got to be able to be understanding. If I'm going to think correctly, I have to be understanding. We've got to adjust our lens. And just as we have to go to the eye doctor annually and to adjust and to see and to test, and can we still read? Do we need eyeglasses? What do we need? Going to the doctor annually to adjust our lens, we have got to be able to do that with ourselves daily. I know when I'm gravitating towards someone and I ask myself why. I know when I'm gravitating away from someone and I'm pulling away from, I have to ask myself why. A call to action that I want to give you is, what are you doing to help others? What can you do to become allies to help others? If you see that you are in a, a, a lower status based on maybe being a female in a male-dominated profession, or being a male in a female-dominated profession or specialty, if you are in a lower status, be aware. And those of you that might be in a higher status, be aware. And if you're in a higher status, because that's just some of the realities, be that advocate, be that person who, speaks up and talks up that new physician that says, I remember when I was once a young physician, when this physician speaks in a room and maybe no one else really hears because we want the real experts, be the one that says, I remember when I was a young physician, and get up and speak up. Speak up for that person who might be in a lower status. He just finished residency. He still doesn't know what he's doing. That's microaggression. We avoid that. But speak up and be that ally, be that positive advocate, especially if you're the chair of a department, the medical director, physician that everyone goes to because you've been there for 20 years and everyone sees you as the expert in all areas. Be the one who speaks up for the newer ones in the organization. Be the one who speaks up for the female physicians if there's a culture in your environment where everyone wants the male physician. Be the one who speaks up for the older physicians. Be the one who speaks up for the younger. Be the one who is an ally. This is a call to action. Be the one who speaks up for the APP that you're working with. When they say, well, I don't want to see that person, be the one who speaks up to go, you know what? They will give you more time and spend, the time that you need and provide exceptional quality of care to you. A clinical care to you. Speak up, so important. Always remember, before you speak, think. Again, is it true? Is it helpful? Is it inspiring? Is it necessary? Is it kind? If it isn't, don't say it. Adjust your lens to get rid of distractions. I'm sure most of you remember, if you are in my age range, at least that moment when you turn down the radio so you can see better. And I've done that many times when I'm driving in the middle of winter and all of a sudden I turn down the radio so that I can see better. The reason you turn down the radio is 11 million pieces of information per second. You want to focus on what your eyes can see and you don't need the distractions from your ears. So you're trying to amp up, what your eye gates can see and reduce all the other extra noise so that you can concentrate. So adjust your lens and get rid of a lot of those distractions that can prevent you from treating your colleagues in the way you ought to, from treating patients in the way that you ought to, from the distractions that prevent you from being consistent. Now, we know all of you provide exceptional medical care, but it's those little things that can increase your patient experience. That little gentle touch to a patient, that smile, the way that you greet, the way that you introduce yourself, the way that you behave. The non-clinical aspects is what I'm focusing on that can really make a difference in the life of the patient. Because if the non-clinical aspect is focused on and you get rid of distractions, it could then impact the clinical. You might be on your way out when the patient then says, oh, I have one more thing. And that one more thing might be the real thing, the real reason why they're there. and they've not spoken up. They've talked about everything else, and they finally say, I have one more thing. I found a lump. The smile, the encouragement, being present has now given that person the courage to speak up about something that you never would have known. So let's adjust our lens. Let's get rid of distractions so that we can help our patients in ways that improves outcome. We want to make a difference every day. We are one human race, and kindness makes us the most beautiful people in the world, no matter what we look like, no matter what we sound like, regardless of race, gender, anything else that you can think of. Kindness makes us beautiful. And as someone who is in the healthcare profession, and who spends time with physicians, when I've gone in to see a physician, I can tell within a short period of time the level of compassion and care that they have. And it really does make a difference. Our time is up. Looking forward to questions in the chat, and if I can answer them, I will. Have a wonderful rest of your day.